of Governors has disappeared. Bill. Other bill. There it is. Okay,
You're alive.
we are live. Okay, this is Senate Finance. This is April 2nd. So we missed April Fool's Day around here, which was probably good. And we've got a pretty full agenda today, and then we need to do some committee discussion. We're gonna continue with, the miscellaneous tax bill, H 546, and act relating to administrative and policy changes to tax costs. Abby, come on up. Okay, and I guess. What we would like is if you just went over sections, the tax department put in, I gathered there's several at the end, but you didn't. But just tell us what the thinking is behind that. Right, and if you haven't picked up around the rule, the assessment of telecommunications is, I don't know if it's getting questionable or controversial, if there's just one person that's very concerned about it, but we'll take a look at it.
Okay, thank you, Madam Chair. H 546, it's the miscellaneous tax bill. It's
Right now, it has the official price.
Yes, slightly different, otherwise known as miscellaneous tax bill. For the record, Abby Shepherd, I'm now the Executive Policy Advisor at the Vermont Department of Taxes. I'm no longer with Legislative Council, but I'm happy to be with you today about this. I am representing the department, obviously, today. So many of the department's sort of annual technical recommendations are in this bill. And I know you had a walkthrough, but I could just really quickly highlight the ones that are very happy to see made their way across from the House. There's a very small technical change to some appropriation language, making a transfer from the general fund rather than education fund that has been practiced since 2018. That's probably the most technical change in this bill. The next change is regarding municipal reimbursement. So there is a mechanism for towns when they lose an appeal on valuations, they can have a credit against their education payment in the following year. The department, because of the current statutory language, the town has to follow those appeals through until there's no further right of appeal. The department has seen some recent situations where the PBR agreed that best practices had been followed, that the settlement was really fair market value, so it would not have made sense to continue until there was no further right of appeal. So this language follows that best practice and gives the director discretion to say you do not have to continue to appeal because that would be no longer best practice. So that language made its way through and we support that. There's also the annual link up. So that is typically in the miscellaneous tax bill. Sometimes that's in the budget bill. That's when we conform.
How things fall down at the end of the year. But this is one that has to go.
This is what we would definitely consider a must pass because this is always retroactive. It's the way that our forms for personal income tax, corporate income tax, and also estate tax have already been created to conform to federal statutes. There are no major changes that we're concerned about. You may have heard in the news, there was a proposal that made its way from the US House to the Senate that is stalled. So there were some retroactive changes there, but those have not passed. So conforming would not make any major changes to Vermont's tax code. The next section that we had proposed relates to the renter credit. So if you'll recall in 2020, there was a reform that really made significant changes to the program, simplified the filing requirements for individuals. So this is a general fund appropriation. This does not impact the education fund. It's been consistently budgeted. This is a credit for renters. And it's been consistently budgeted about 9.5 million. But the actual spend, particularly following a lot of federal subsidies during the pandemic, has been closer to 7.4 million per year. So to keep that, not spending more than 9.5 million, the department, and I asked Jake Feldman to come with me because he did a lot of work on this. The department's recommendation was to change the income eligibility thresholds. So rather than being about 50% area median income, it would increase the threshold to 65%. And that would expand both the number of renters who would get the credit. So it would pull back in some of those renters who were no longer eligible after the reform, but it would also give a larger credit to many of the current recipients. And it would not exceed that 9.5 million appropriation.
Okay,
So it's using that full appropriation and expanding eligibility for renters.
okay, so keeping within 9.5 million. But increasing eligibility by raising the income.
The income threshold, correct? And those in statute refer to US HUD, so housing and urban development definitions that are set in federal statute. And there are statewide and area definitions and limits.
That's the question.
Okay, yep.
So you said 65%, I'm seeing 1.3 times, what do you mean by 65%?
So it would increase so that's where there's the statutory different definition, but it gets at when I think people are more comfortable using area median income. But it would increase those statutory definitions, which are set by US HUD, and it would be the equivalent of 65% of AMI. And I'm looking for Jake Feldman, who might have a little more comfort explaining those.
So connecting 65% and 1.3.
Yeah, I'm happy to explain. And it's pretty straightforward. Jake Feldman, Tax Department. Can you hear me okay?
Yes, very well.
Awesome. So currently the eligibility limit is 50%. So to get area median income, it's actually what HUD calls low income. It's their 50% of area median. And so to get to 65%, we have to multiply that number by 1.3. So that's where you get the funny 1.3 in the draft language.
Thank you.
Okay. Okay, so without spending any more money, we're helping more people.
Correct.
Good. Okay, do you have other questions? Let's move on.
No, that's just to understand, as I remember, there was a difference if Franklin and Grand Isle were counted as part of Chittenden, and this is to break them out and to treat them for rural, the rest of rural Vermont is treated, or the rest of Vermont is treated. And that is designed to equalize that.
That's correct. And that is current law. That was part of that reform, which passed in 2020, but didn't actually impact renters till 2022, but yes, that's existing.
So it's not the front and being isolated, it's that if they pulled out of Chittenden.
Exactly.
Yeah.
I think it's called the Burlington Metro Statistical Area.
Yeah.
Something along those lines. So this, yes, it pulls them out of the
Yeah.
Burlington area.
No special treatment, right?
1.3 times as much as everybody else.
Okay, let's go on to the next one.
We had also requested. Right here, also requested eliminating a late fee for property tax credit claims, so that's a $15 late fee for those filed after the April 15th due date. With our current processing, most of these claims, or almost all of these claims, are able to be processed almost immediately anyway, so the $15 fee is creating more of an administrative burden than the actual revenue that brings. I'm sorry, I should also explain that $15 goes to towns. So that would not be a state revenue loss. It's estimated to be about an $88,000 loss total for all towns. So the median impact is estimated about $225 per town. And that would be to greater administrative efficiencies. So we were happy to see that made its way out of that as well.
Yeah,
Quick question.
yes.
Now, is that because, although the state's collecting, you're dispersing to towns?
We would be
You
dispersing
were
them
basically
50.
collecting and passing through.
Yeah, so
So now
that's,
there's no money to pass through, if you move the various.
I guess
we would
we're
retain
here on
$15.
town's plan. think we'll hear from the town clerks on this one.
Do you know what the total revenue generated by that fee has been?
So total fees across towns is $88,000. Right, minutes. So it's about average impact per town is $343, median impact is 225, or that's per town.
So the credit, and we have multiplied by 1.3. Or
Perfect. And then there was also a request from the department regarding utility valuation. So Madam Chair, I did hear you say telecom, and that is not what is being addressed.
Okay,
So
utility.
there's a separate bill that deals with telecom valuation that the House, I believe, is voting on or has just looked at this morning. That's still in the House. So that change summarizes as
What's,
current law.
seven,
7.
That is.
the other guy's seven, the valuation changes is 8. 7 is application.
Oh, I'm sorry, yes, there are 2 sections that repeal that $15 late fee. That's why.
Okay,
That's section 6 and 7. So section 8 is the utility valuation.
Around for half the rest of the year, so it's.
I'm not sure, we hear from the town clerks, I'm sure they will. Okay, that's. Okay, there we are.
So currently, the way that public utilities are valued is that the department provides a form. At the beginning of the year, the utility fills out the inventory and then has to send it back to property valuation review by the end of March. And then property valuation review provides that to towns to set in their grand list. Under current statutes, towns can contract with outside experts to take any other information into account. That's where they're looking at fair market value. The department very specifically for electric utilities has been working on a new methodology to provide that valuation to towns. What this language would do is require towns to use for electric distribution and transmission only, so not for other types of utilities, to use the PVR values. And then PVR would also have the discretion to require values for other types of utilities, but our current plan is to roll out electric only, and that will be starting on next year's red list.
The question I've kind of gleaned from the emails is what happens to the towns that have a contract with an outside appraiser? Can they run out that contract and still use, they have to accept yours?
So they would be required starting next year to use the PVR values for electric. I don't know
About
the
others.
parameters for the, I imagine those appraisal firms are doing other appraisals for the town, but I
Okay,
defer to those towns onto the scope of that.
okay. Senator Gray.
Thank you. So is the idea in part that you're looking to see steady valuations as opposed to somewhat ad hoc by individual contractors, hiring individual lifters, who knows what comes out?
Correct, and I also should have provided the background of, because electric utilities can appeal those valuations, that to provide more structure statewide, so it wouldn't be a town by town. In either case, towns are trying to get at fair market value, our valuations are also getting at fair market value, so there you still do have some guidelines. It's not that the state will be setting values arbitrarily.
Yeah.
It's that it would be the same statewide, the same methodology.
And it says transmission and distribution,
Correct,
but not generation.
that is correct.
Okay,
So that would apply to poles and wires, that would not get at dams or other generating facilities.
because
but
that's where there's been significant controversy.
correct, the department is not prepared to begin that methodology.
Connecticut River generating stations, for instance. Okay,
Methane digesters.
Yeah.
Much more complex projects.
Senator.
The valuations that are furnished. What's the basis for the valuation? Is there a specific basis or way the valuation is computed?
Yeah.
Or do they just make it up on their own?
Oh, currently, or what the department has been working on? So typically what has happened is towns have contracted with outside expertise. And the department is currently working with an expert that is creating this valuation model. I am not the best place to explain how it actually functions, and we could come back in with more detail.
Well, I guess the only question I've got is there in fact a methodology that is uniform across the state? And is it a methodology that could be audited?
So currently,
consistency.
no, that is part of the concern, is that it is not a uniform methodology. In terms of auditing, I'm not sure, I know what the state would be providing. You're asking whether that could be audited?
Well, no, I'm, in terms of the valuations that are being used, they're being computed, I assume, or will be computed using a uniform method. And then then presumably that can be audited to determine that it is consistent across municipalities and that the valuations are in fact reasonable, that the valuation model is working as expected. And is anybody charged with doing that? I guess is a really difficult question I've got, or do they just sort of make it up and submit it, and so long as they submit it, everybody says it's okay?
Yes, I would have to bring that
Like
back to our
ED5.
PBR. Yeah, let's see, yes. Well, there would still be so the town could still, I'm sorry, currently the sort of audit is that there is an appeal and then it goes through the full process. I guess I would want to change that.
I guess the final line question really is, how do we know it's right?
One more question.
Thank you for your question.
Senator Bray.
Do you have any idea how common or uncommon appeals on values for transmission and distribution infrastructure is? I think it's coming up enough that it's current our attention, or it's.
That is my understanding, but I do not have the numbers. I believe we should be able to get that, although it typically starts at the town level and then works its way through, so I would need to follow up. I need to ask our PBR director if she has those numbers. But yes, it is certainly, you might want to hear from public utilities and electric utilities in particular to get their perspective, but I can see if we have numbers on that. I'll have those up.
I think we're set on that one, could probably move on to the next one.
Okay, the following, I believe after this section, so the following sections 9 and after are all additions from the House. I understand, let's see, so section 9 is a property tax exemption. Department is neutral, there's no there, that's for county owned property. The extension of the fuel tax in section 10, so again, that's a administrative change, that's not camera neutral. There's the extension of health IT funds, so there is an allocation of the healthcare claims tax that has been pushed out over the last few years, either a year or 2 years at a time. So it was not expiring this year, but this language does extend that sunset 2 years. So presumably.
At what point we made these things permanent? Right,
That's certainly this language keeps it in session law.
okay,
But that would extend the sunset another year to 2026. So it will force the conversation here.
yeah, okay, is that the end of your sections?
Those are the end of our sections, and then we did have comments on the 2 study groups if you'd like to hear those.
Yeah.
Perhaps not surprising. So starting with the local revenue working group, we had a few comments and just generally wanted to express that the department in general is not eager to take on this work. It is almost entirely executive branch members as well as the treasurer and the LCT. We understood that there was a nice or fairly comprehensive, robust study from JLO that came out this year. And it seems like the next step is making policy decisions, and we're somewhat neutral on a lot of these questions because it is about local revenue. So we're not deeply interested in this study, particularly because our resources are focused on the Act 68 H480 report right now, the reappraisal on property tax sites. report. We're really putting a lot of work into that. We've also, we have the childcare contribution that's going live in July. We're also working on our VT Pi system for property evaluation and review. So our general, we see as well, there isn't a directed staff or assistance in the language, so we're concerned about being tasked with this report in particular.
Did this, or maybe everything from here on, come out of Ways and Means?
That's
I guess added by Ways and Means.
Yes. And I don't believe we have testified at either of these studies or working groups yet.
You mean what if we asked if you have time to?
Sorry, I'm
I
sorry.
said you want to be asked if you have time to staff. Okay. Next one is the wealth tax, is that it?
Yes, so the wealth tax, I assume it's not a surprise that the governor does not support the idea of a wealth tax, so the idea of a study is not extremely palatable either. Some of the concerns that the department has had are looking at this issue on the national level, that it would really put Vermont out at the forefront. This is a very contentious issue that Vermont would be the very first to be doing this, even if it were just a study. As is the proposal here, this is very much a pared down version from one of the bills that was introduced in the House. We are concerned about this happening at a state level. We really think it's best dealt with federally. Our particular concerns as a department, again, are the staffing resources and time committed to this particular study. We understand it isn't due until 2025, but we would prefer to devote our resources to other issues. And we just wanted to point out as well that while tax flight and tax avoidance is sort of that very hot topic debate, it is an unknown, and would point that out, that it's not an obvious conclusion that it won't happen. So there, both sides can argue it will or it won't cause tax flight or tax avoidance. So either individuals leaving or shifting of revenues outside of the state. Again, that's where that concern about the state trying to address this is not as effective as if it were a policy decision. The federal level is the appropriate place to address that.
Senator Quinn?
So I don't know if you have any information on this, maybe commissioner question, I don't know. Sometimes we hear that even having a discussion about things like this, people make proactive or preemptive choices and may end up with a negative impact that we don't anticipate. I don't know if you have any data around that. I don't know if those are apocryphal stories that are always arguing against doing something, or you actually see that kind of correlation.
So there are different studies in both directions. But certainly we have looked at some of the studies out of Tufts University, looking at California in particular. And there are you can see that there is some tax flight or tax avoidance. So there are two, I really want to be sure that those two issues are separate, because one is about
Won't come here.
high,
That's what
right, correct. And again, those are difficult conversations to have, because it's hard, you can again do it both ways, but one is about perceptions and the other is actual behavioral changes. We were remembering as well the estate tax change that was made a few years ago, and that is a much less sort of aggressive proposal, where Vermont did decide to follow a little more closely the federal exemptions, because we were hearing from practitioners that individuals were making behavioral changes about where to have residency for state tax purposes. So you can find anecdotes, you can find examples of individual, I would be happy to share different articles again.
I don't know
You can find
how far
both.
we'll get into it.
Well, considering having been through it at least 10 times, the chair has banned discussion because nobody's mind ever gets changed. You can find studies on both sides, and you either believe one or you believe the other. And we've never come to a resolution.
It was one of those, that whole thing reminds me of the portal of anecdote is not data. Who knows? Can you distinguish, sorry, between, you said property, tax avoidance and
Right.
tax flight.
Sure.
But I'm just wondering if tax flight means you really uproot yourself and leave entirely, or you just change your, where you live so that you're not a resident of the community, but you still keep your home here for a second home. Right?
Yes, I think that's I think it's both, the tax lay, it's changing your residence, that's could be, but then tax avoidance is more do during for assets. And the version that was introduced in the House was primarily looking at assets.
Okay. I think that's it for the tax department.
Thank you. And I will
Okay,
follow
thank you.
up with
You'll hear more from us. I'm sure, when we get through this. I already have one declaration committee, I'm thinking of hanging on this tree, which is the towns have requested an extension of that flood abatement, because not everybody apparently has requested and they just summarily check across the hall, and they don't have a problem, so we'll take some testimony, I've got it lining up, but that's the one decoration we can see coming for this bill.
So I sent you some emails on this, and I just don't want to drop the ball from Senate Transportation. They charged me with another declaration to consider
Yeah.
ATV tax and private sales to just get consistency with
Okay.
snowmobiles.
So those are the two anticipated decorations. Senator Gray,
Do you know who, there's a section 15 here, fees for copies, who's the state registrar? Now,
that all got put on by the House. So. The state registrar. We will see if we can have, I assume the chair of Ways and Means, see if somebody from Ways and Means. Probably the chair can come down and explain to us their sections. We are supposed to be moving on up. We have Ed McNamara's confirmation. He sent all of us his resume. He was in on Friday. I would appreciate, actually, we sent it upstairs, right? Did that, Matt?
Yeah, that one's
we voted that.
We voted that
Yes,
one.
we have.
That's what- Okay, so is anybody, you,
4 more.
four more, okay. You can give them to me and we'll see whose district, right? Well,
Gifting and.
this is Mark Foley in Rutland. Vermont Municipal Bond Bank. Senator McCormick, do you want to do that one?
Not mine, but I'll do it.
Well, I know, we're just gonna have someone from every. John McSorley, member of the Vermont Municipal Bond Bank.
Yeah, I know.
So what did you, John?
Yeah.
Okay, I was gonna say I do him, but. Since he's on the VSAC forum. And did the best presentation on an audit and what it was actually entertaining. He was really good. Okay, Deborah Winters, Swanton,
Which one is?
Deborah
Oh, yeah,
Winters,
sure, I know. her.
you know her?
Yep.
Here's yours.
I thought I did this
Okay,
before.
yeah. David Snedeker, Eastern Avenue and St. Johnsbury. Senator Chittenden, you're as close as anybody. in St.
I
Johnsbury.
knew that.
Okay, I hope they have copies of those.
Oh, I was having to have them,
Oh,
but I,
okay, why don't you give those back? We'll get copies and we will get contact information.
Yeah,
Yeah, that'd be.
and
Why we have
resumes.
to ask the administration every year for contact information,
Yeah.
I don't know.
Usually it's wrong.
It just makes us a little annoyed.
Yeah.
Last time I recall, the last time we did this was last year, but almost half the addresses and phone numbers and so on were wrong. And the one guy over here did get a hold of.
That's right, remember that. They-
We appointed anyone?
No, I don't think we did.
They might want that, okay,
Madam Chair, would it be acceptable for this communication to the fifth floor to go out from the chair in behalf of the committee?
we've done that communications for years, if they haven't gotten the message, they're not going to.
Mhm.
I mean, it would just be so easy to stick an email,
I mean, they've got it.
I know. So we'll try again.
Well, it's
Okay.
also not so great on their side, because now they feel individual requests like over and.
Yeah.
It's just
Okay, we have,
print the
I
database.
just watch it.
what is this?
They have extremely limited time. The two doctors are
Oh,
coming.
all right, we
They
have
have
two
15
doctors at
minutes.
2:15, so I'm not gonna let you out of the door because they have very limited time. And if I let you out of the door, you can go one at a time.
I just drink coffee, so.
Yeah,
Right.
but I need a quorum here for the doctors. Yeah,
The house has asked me to come up. When they're off the floor to introduce the, but they're on the floor, I think. And so they're gonna.
Okay.
Or
If-
reach out to Zane or.
as long as I have a quorum, I don't know where Senator Ryan is standing. And what he wrote. Today, I think several of the tax bills which were attached, the tax was added to fund the bill. I think two of them went to other committees today. I've asked the pro tem to tell them that there's a likelihood we might not pass the taxes, so. But we're gonna have Chris Wood come over and tell us where the taxes are, because it's sheer more than just a tax bill. We've got that, the pro tem has said, and I still think we're gonna be doing school funding most this year, that it looks like the governor would approve some tax increase to offset school taxes. The most likely way to do that, the easiest way would be the cloud tax. Because it is a sales tax and therefore it would automatically go in. Would be a drop in the bucket, but it would be some help. I think it's about 20 million.
2 cents.
So,
Well, and you partially argue that the cloud tax is really a substitute for taxes on software that used to be bought over the counter.
right,
And so it is really a continuation of the tax that really
Yeah.
exists now. It's just a different way of collecting it.
so that's been the argument.
That's an argument.
Day one, but I think. We'll start with Ted. Anybody knows anyone that would like to talk? I'll start with the Chamber of Commerce, so we get all the. Concerns out on the table. I believe close to half the states have done it, so we aren't outliers. So,
It's the Vermont Software Developers Association.
okay.
It's
So
interesting.
get that one. What?
I'm just trying to remember the last time we took that up. And it's gotta be 3-4 years ago.
We took it up, we've taken it up and dropped it a few times. We
We
did.
took it up and we took testimony,
Yes,
as I recall.
we did.
And I'm just interested in, who and the organization that testified the last time we did it. That's what I was getting at.
Yeah, so we'll see if we find, I know there were two brothers, one lived in Montpelier and one in Burlington. There's also the Vermont Center for Innovation, right?
Yeah, that's,
That there's a lot of business.
Yeah.
Kind of innovations.
Morning, I think it's made things more clarity.
that's, I think who ran that, can't think of his name.
Yeah,
Some.
we will
sort of
talk to the
public
chamber.
Right person.
Yeah.
So was that?
It's in downtown
Yes, it's part of UVM.
Yeah.
And it was mostly, I thought, computer innovation. There's Center for Innovation at UVM.
Think so.
Yeah, they would, I think, would be people to contact on the cloud tax. If you think of anybody else up there, that would be helpful.
Yeah, it kind of rocks up, bringing it up. It feels to me like it was pre-COVID that we, because I remember. people
Yes,
were
oh,
here,
it was
it
definitely COVID.
So it was a while.
And it was the end of the session because it was getting warm. For some reason, I remember being quite warm. And we had a lot of people in it, so it was definitely because we weren't using the screen. But it's not new anymore. So maybe it's not like we'd be the only state. What do I do if I'm selling to somebody in Nebraska and they don't do it? I assume some of that has been worked out.
It may be that by now, we actually be joining them or getting out ahead of other people.
Yeah. I think that's where a lot of that happened. Okay, so we've got 4 minutes before we have our next witnesses. And we've got 2 compacts to get out today. Nolan has sent us, and did you get it? It's on the website. A fiscal note on the compacts. These are all the compacts we did and the losses. The loss is that they don't pay a license fee in this state. We're trying to get Office of Professional.
They will be here.
They will be here, and Senator Lyons is going to talk to us about this social work compact because she's the author of that.
I don't see that on the website.
Yeah, I just got an email.
It's coming. Basically, we're losing money. Yeah, these are the ones we've done, and the total is 18,000, 79,000. It's a high and low estimate for these last period. However, I think we've let genie out of the bottle. Once we started approving compacts, nursing, I believe was the first one we did. It was a big step. Does help travel nurses. And this seems to be the wave of the future. It's just almost like national registration. Which we've done with insurance and a couple other industries with compacts. Not because the feds were breaking to take it over. There's Jen. Okay, Jen, we still are waiting for our 2 doctors that, well, we've got 2 minutes to go. So you're a little early. That's fine.
We were having this issue, I really create from that in.
Oh, last time I saw Claire was about a year ago in the airport. I was coming back from a conference and sitting in Kennedy, I think, and she came up the other runway and came through, and I just saw her walk by, and I said, that looks like Claire Air, and it was. Visiting grandchildren on the island.
Just where she came back.
Okay. Are our doctors going to Zoom
Yes.
in? Okay. They're very punctual. They have about 45 seconds.
We give them 75% of our attention since they're going electronic.
If I could get 75% of everybody's attention, I'd be really.
Audio or audio? I'm gonna write it today.
I don't know, ban. We used to ban electronic devices in committee, then we decided to go paperless. But then half the world wanted paper anyway, so now we have the piles of paper and the computers, which are a temptation to look at other things.
We need larger desks.
I just want my floor back, the new table.
Yeah.
I share, well, Senator McDonald's drawer is down there somewhere, and I'm supposed to use this, it doesn't work.
We've kind of got 2 drawers, you know.
Sharing a drawer with Henry McDonald is hard to make.
Hard. And I used to have a shelf that pulled out here, and I could just put my agenda there, and they were all rustling around with paper. I didn't lose my agenda, which I regularly lose now.
You know, it used to be file cabinets.
Oh, yeah,
Um,
but nobody was keeping all their files because it's all on the computer, so. They're gone.
In those days, I was keeping.
Just like some
Oh, everybody.
power cables up here.
Yeah.
Yeah.
We had a lot of them because Rachel and I also had a second drawer.
was it in here that
Our process join.
sat next to Senator Air? And he got like yellow and black stripey.
Yes, we did. To Margaret, I'm coming close to doing that. All right. So, welcome. This is Anja Ben Beckler. I'm sure I've just massacred your name. But welcome and we're talking about H 861, which is the reimbursement parity for healthcare services delivered in person by telemedicine and audio only telephone. So the floor is yours. Just introduce yourself for the record.
Hi, I'm Anya Van Berkelaar. I'm a primary care doctor, family medicine specialist at Battenkill Valley Health Center in Arlington. And I really appreciate the opportunity to speak to you about the importance of this service. Shall I just jump right in with examples of how we use this service, or would you like to ask questions?
No, I think just jumping right in would be fine.
All right. So the use of phone only visits is generally not my first choice when I'm trying to see a patient, but in the circumstances we face here in Vermont with our significant elderly population, lack of widespread broadband internet access for at least significant swaths of our community, generally stratified by income, and sometimes purely weather conditions, sometimes it's necessary. And the investment we make as a health center for an audio only visit is not materially different from the investment we make for an in-person or a Zoom visit. Of course, with video capacity does cost us a little extra. We pay for a service that makes that HIPAA compliant. But generally speaking, my medical assistant participates in all these visits in the same ways broadly as she would in an in-person visit. She will review the medications with a patient, capture their chief complaint, ask them screening questions. And this is increasingly important in the context of the amount of mental health care that we do in primary care. We use standardized screening tests or surveillance tests like anxiety screenings and depression scales so that we can assess the progress a patient is making in their course of disease and treatment. And so that investment of time on my medical assistant's part is unchanged. And that then leaves me the opportunity to really get into the meat of the visit with a patient, talk about their medication side effects, their coping skills, talk about whether they feel like they need an adjustment to their medication, and also provide anticipatory guidance on what they might expect over the course of the next few weeks or months until their next visit in terms of their body's response to a medication. I'm using the mental health example because it's a very common one. Probably 30% of my visits address mental health or substance use in some form, whether it's tobacco, depression, anxiety, eating behaviors, sometimes more severe persistent mental illness. But the same process generally also applies to other kinds of visits, including something as concrete as a blood pressure follow-up. Sometimes I'll have a patient who was seen at a specialist's office. Let's say they went to their podiatrist, they had their blood pressure taken, blood pressure was high. They've now gone home, they've monitored their blood pressure for a week, and I want to review those home blood pressures with them, talk through all the medications they've tried in the past, the side effects they've had, identify what the ideal medication is for them in that context. They don't have the ability to connect by video, and being able to do that by phone saves them a trip in when they've sprained their ankle or or are otherwise unable to come in. And so for these reasons, these visits, they require the same level of cognitive and a kind of medical labor on my part. It's just that they're happening through a different avenue.
Question, Senator Gray.
Thank you for that. And, we've talked a little bit about the benefits to patients in terms of not having to travel, saving them potentially hours, depending on where you are. But this one area of concern I've heard is that when a patient is there in person, that the way they walk into the room, their energy, their power, that there's like 1,000 clues that a physician can, or a caregiver, whoever is in the office can pick up on, and it helps with, the assessment with what that patient's health. So, do you have any concern about missing information that you would otherwise have if we relied more heavily on in-person visits, or maybe, I mean, audio visual is a step in like, a little step better maybe. So can you just talk about that a little?
So you're correct that the appearance and as you say, the way a patient walks into the room or as they're checking into the waiting room. Even my medical assistant's impressions, wow, Mrs. Smith seems a little wobbly on her feet today. That said, and so for that reason, I certainly wouldn't want a telephonic connection to be my only contact ever with a patient. But as a follow-up visit, or even as an initial mental health visit in certain circumstances where they just couldn't come in person, I do think that these visits have a very important value. Can I capture more physical information in person? Absolutely. I really pride myself on my physical exam skills. But I think that there are certainly visits where I never lay hands on a patient, even when they're in person, because the purpose of that visit is counseling. And so, for example, for the cancer diagnosis visit where I've already examined the breast mass, I know what it feels like, I know what it looks like. I'm now sharing a diagnosis with a patient, and she has, she wants her husband to join the phone call. He's in another location. They can all be present for that visit over the phone as we talk about what the future holds. I think those are the circumstances where this is really valuable. And I think you need to rely on kind of the fiduciary responsibility that a physician or another clinician has in making a good judgment call about which visit types are and aren't appropriate. I wouldn't want to evaluate a pneumonia over the phone for sure. But for many of the visit types, it really adds a tremendous amount of value for our patients who at present feel kind of poorly served when we say, you know what, we can't pay the bills if we just see you by phone because it pays, a quarter as much.
Sure. Thank you.
Senator McCormick.
Does the medical profession, as a profession, have standards of when in person is called for and when by phone is acceptable?
I couldn't speak for the profession as a whole. There may be something published by the AMA or other professional societies about this. In fact, I'm sure that some literature has been produced to this effect. I'm not sure I can answer that question without doing a bit more research, but I'm happy to get back to you on it.
I would appreciate it because it's not just my instinct. I think what is often common is that professions, almost by definition, are somewhat self-regulating. And that we could say that the government we should keep our noses out of it. Of course, there is a question of insurance payment, but that we should defer to the judgment of the professionals. But that I would want there to be some professional standard.
That does make sense to me, and I can look further into that and share that with Mary Kate Molman to pass on to you.
I appreciate that.
Okay. I have not seen any other questions. Thank you. Our next witness has joined us, Heather Stein. So, Heather, you are there? There you are. Welcome to Senate Finance. Just introduce yourself for the record, and the floor is yours.
Hello, my name is Heather Stein. I hope you can all hear me. Speak up if you can't.
Yeah.
Yes.
And I'm a physician. I'm board certified in family medicine, addiction medicine. Worked in Vermont for 15 years. I've worked primarily in outpatient medicine for the last several years at a community health center, much like my colleague Anya, who just spoke. And it is a federally qualified health center. So to sort of go into my statement, which is pretty brief, and then I'm happy to answer any questions that people might have about things that I mentioned. So we started using telemedicine in our practices largely at the youth clinic prior to the pandemic, and like many offices shifted to majority telemedicine during the height of community isolation. Since then, most of our practice has shifted back to in-person because of the benefits of being able to do physical exam give you an immunization, check vitals, do lab work. But there are circumstances where it's appropriate to evaluate someone effectively through telemedicine, and it remains in high demand with patients. The process, from my perspective, is that they appear on my clinical schedule as a particular visit type after they've been requested by a patient to our schedulers or scheduled by a triage nurse after a phone call where the patient was evaluated and recommended to have a visit. Then they requested to do the visit without coming into the office, and a staff member felt it was appropriate to do so. So say like if they had chest pain or reported high blood pressure, we would definitely want to have them come in person. Then the last layer is I review my schedule, and most clinicians do this, and look at any patients and reasons why they're coming in to make sure that we can effectively manage those through video. And then on occasion, sometimes we'll do a visit, and then we'll realize that there's some either treatment or evaluation we need to do. So we'll have the patient come in later in the day. And that's all inclusive in the service. We do not offer audio only to our patients as a sort of advertised service, because as an option, the video component we feel like is really important for as much evaluation as we can get. And several insurers, principally Medicare, don't reimburse for audio only visits. But if we run into technical issues, if somebody already had a scheduled visit, we will do our best to meet the patient's needs in whatever way we can, meeting the patients where they are. Our medical assistants at our practice are a huge part of the piece of how we get telemedicine working. They call patients, help them download apps, see invites, they help them get their sound and audio working. They introduce the telemedicine consent that's going to be done by the prescriber or the clinician. They are really, truly incredible examples of kindness and tech savvy. This is sort of a part of medicine that didn't largely exist in the role of support staff, so I'm highlighting it just because they do it so well, and it really is very much a labor of love. The patience with which they and all of our support staff work with patients who are often older, maybe less comfortable with technology, may have mental health or cognitive barriers, when there are many other demands on there in our time is really impressive. Some of the reasons that patients routinely request telemedicine instead of coming into the office are their own convenience, barriers to transportation, mud season, snow, distance from the office, particular weather. Driving at night actually becomes an issue later in the day in the winter. Work schedule. So doing a telemedicine visit can be done sort of during a work break in a day. They can kind of escape to a private area, whereas often to go into a medical office and be evaluated, they might have to take a half day or have reduced income. Or they might be caring for a vulnerable family member at home. And I have a few examples of where I've found telemedicine helpful in my clinical practice. The first one is that standard of care for us after we start a new medication for depression or anxiety is to see a patient back in 2 weeks. The most important reason for that is to assess suicidality, but it's also to make sure that people are doing okay on the medicine, that we don't need to change the dose, that we don't need to change the medicine. Since we've already in many cases done an in-person evaluation first, this is a great opportunity to do telemedicine, make it easier for the patient, make them more likely to show up, as it were, and be able to see them in their home setting. Chronic visits for patients who we see very regularly for principally medication management, think chronic pain, ADHD, use disorders. While it wouldn't be appropriate to see every visit as telemedicine, because there's definitely some in-person evaluation, having every other visit, being able to see them again in their environment works really well. Hospital discharge visits, I've actually been doing quite a few of these because oftentimes people are homebound, either in an acute fashion because they're sort of debilitated after whatever brought them into the hospital, a surgery or significant illness, or they were chronically homebound and are out of the hospital. A lot of times there's new diagnoses, test results to go over, new medications to discuss, and caregivers to coordinate with. So this is kind of taking the place of the home visits that are really challenging logistically for us to schedule. And then coordination of care. Over just the last few weeks, I've done a few visits where I've brought in multiple team members who are kind of all over the Chittenden County area. So one of those was a patient who was sort of a frequent hospital utilizer. We were trying to keep her out of having to go back into the hospital. So she was on the call. Her Howard Center case manager was on the call. The head of the infusion clinic was on as a nurse. I had a recent telemedicine appointment with a patient who's a drug and alcohol rehab who was struggling with one of his medications. And then a recent call with a patient, this was a hospital discharge as well, but they had just gone on hospice. So it was with the patient, their family members, and the hospice nurse who had just arrived at the time of the visit. I know this committee had some questions around appropriate billing codes and how those are determined. While there are many billing and procedure codes, the number we do through telemedicine are necessarily limited. In our office, it's generally follow-up problem-based visits, and we would bill either based on components of the history, exam, and follow-up tests and coordination, or bill based on face-to-face time with patient. The call cannot be a follow-up visit within the last 7 days. And if we do ask the patient to come in person, they're billed for just one code inclusive. So say if I see a patient for headache and we determine that we need to have them come in and do a blood pressure and receive a medication in office, that would all be one code for all of that care, even though it happened over several hours. Happy to answer any more specific questions. And we do lean heavily on, we have a couple people who are sort of coding experts who help us make sure that we're compliant with all the different regulations through different insurers. And just say I'm in support of specifying reimbursement and parity in statute because DFR has testified this will not increase healthcare costs or premiums. It'll allow primary care offices to continue to offer this service, which is really beneficial and in demand by vulnerable Vermonters. Most primary care offices in Vermont that are not part of UVM Health Network are operating either at a very thin margin or a loss. The FQHC in which I practice has been the only set of primary care physicians, nurse practitioners, and physician assistants openly accepting new patients in our area for the last few years. And we're really struggling to meet the needs of our existing patients as well as continue to bring in new Vermonters, those who've been going out without primary care. If we're faced with dramatically lower reimbursement for telemedicine services, we'll just have to stop offering them, even in cases where it is clinically valuable, like the ones I described. Just want to say very much thank you for your time, and I'm happy to answer any questions or clarify any of my statements.
Thank you for your time. I think the one thing that's in question here is not telemedicine, but audio only. And you said you do not offer that because Medicare doesn't pay for it.
We don't advertise that we offer it. So what ends up happening that leads to audio only in most cases with our patients, and we're lucky that most of our patients are in Grand Isle or Chittenden County, but it often happens that, say, Teams doesn't work, Zoom doesn't work, their phone just broke, and we do provide an audio only visit in that setting. So we do audio only. It's just our last resort after we've tried everything else.
Okay. Any questions, committee? If not, no. Okay, thank you very much. This is helpful as we're getting our hands around this. We have new. Okay. Okay, thank you. Committee, we actually have 10 minutes. Jen, can you wait until? Okay, I'm going to give you a 10-minute break. If you're not back here at quarter off, you will never get another break. Because I am going to need a quorum, but we're going to start going through. We've got two healthcare compacts that we're going to go through. And one, the appropriations chair would like us to get out today if possible. It goes to approps. And there was a Scribner's error technical correction they need to make, and this would be the one appropriate bill for appropriations to put it on. So there seems to be some anxiety about that. Okay. Go.
Quarter up.
Quarter off, yeah, we're running through.